should have been there.
Well, corneal ectasias are like hernias. In hernia, there is a weakening. So here, there is a weakening of the collagen of the cornea. Cornea becomes thin and it bulges out. So keratoconus, pellucid marginal degeneration, keratoglobus, pterian marginal degeneration, and post-LASIK ectasias are the types of corneal ectasias I'll be discussing. Coming to the most important, keratoconus. No matter what definition you look up, it is essentially a corneal thinning disorder which causes apical protrusion and irregular astigmatism. It is a slowly progressive disease, bilateral, but can be asymmetrical. Female preponderance is there for the disease. So coming to etiology, it can be genetic or environmental. So some of the important ones are enzymatic imbalance, allergy, or eye rubbing. Traditionally, in textbooks, it is described to be non-inflammatory. However, new reports suggest that inflammation can drive keratoconus, and it is probably a localized disease. And this recent study published shows that defective autophagy due to oxidative stress can also cause keratoconus. Many ocular conditions are associated with this disease, and the most important ones are mentioned here. But I feel vernal keratoconjunctivitis is very, very important, and also any disease which triggers eye rubbing can lead to keratoconus. Some high-risk factors causing progression of the disease include age. Younger the age, more is the risk of progression. Atopic eye disease, pregnancy, frequent change of glasses, eye rubbing, dry eyes, systemic deficiencies like vitamin D and B12 deficiencies, contact lens intolerance, and allergies can lead to rapid progression of keratoconus. Some of these are the systemic associations like atopic dermatitis, Downs, ED, Marfan's, Cruzon, and osteogenesis imperfecta. So coming to the symptoms, patient will typically complain of blurred vision, frequent change of glasses, ghosting or monocular diplopia. There can be glare while the night driving and some tiredness in the eye. So coming to the signs, you can do retinoscopy, keratometry, DO, inspection properly, and slit lamp examination. So the patient can have progressive myopia and irregular astigmatism. When you do an undilated retinoscopy, you can find scissoring, jumping reflex. Then you can have Munson's sign, which is the bulging of the lower lid in the down gaze causing this kind of picture. There are some more signs shown in the picture. And when you do a distant direct ophthalmoscopy from a, say, half-meter distance, you will see a delineated oil drop reflex. Slit lamp shows apical corneal thinning. If you make a very fine slit and move it across, you can see apical corneal thinning. You can see prominent corneal nerves and Fleischer ring. Fleischer ring is nothing but epithelial iron deposits, which may be at the base of the cone, and it's best seen by cobalt blue filter. Then you can see walk striae. Walk striae are very fine lines. These are deep stromal stress lines, which disappear on applying pressure on the globe. They can be acute hydrops, which is caused by the rupture of the stretched descemet membrane. And you can see, of course, scarring at later stage at various levels in the cornea. Investigations, very important, corneal topography. All the LASIK candidates undergo this test to rule out keratoconus because KC is a contraindication for LASIK. All the patients should be screened by topographer prior to any laser vision correction. So characteristically, you see astigmatism which progresses from asymmetric bow tie to a inferotemporal steep cone. Okay, and it can be graded on the basis of highest axis of the corneal power as mild, moderate, severe. Mild is where the steep keratometry is less than 48 diopters, moderate 48 to 54, and severe more than 54. So this is an OB scan, and I'll describe few very important red flags which you can pick up for a keratoconus diagnosis. So the keratometry of more than 48 diopters, thinnest pachy less than 470 microns, skewed radial axis of more than 21 degrees, and irregularity in 3 millimeter zone of more than 1.5 and 5 millimeter zone more than 2.5. There are many more diagnostic criteria, but these are the few important ones you should keep in mind. This 3 and 5 millimeter zone cutoff is also included in the F-Carpidis criteria for diagnosis of keratoconus. This is Chromix classification, also widely used, but this is little outdated. Now coming to pentacam. I'll describe some red flags on pentacam which you should keep in mind. So any steep keratometry and inferior irregular steepening should be taken with a pinch of salt. Then anterior elevation more than 12 microns, posterior elevation more than 18 microns. And then when you look at the pachymetry map, the apex is slightly, the thinnest point is displaced from the apex. It is not coinciding. Plus, there should be a coincident point of anterior elevation, posterior elevation, and the thinnest pachy, which is not seen in pellucid marginal degeneration. Also, in the bad display, a value of more than 2.6 can be suggestive of keratoconus.
Excuse me, Shruti.
Yes.
Since they're all resident sitting, could you also highlight, go back here. Also on this, when, like, of course, this is typical keratoconus, but we do get cases when we may have just simple bow tie astigmatism here, and when it is not a keratoconus, but labeled as a keratoconus. So what are those like few things which you definitely need to have in pentacam to label it as keratoconus?
First, you should always check for quality scan. Not all inferior steepening is keratoconus.
Yeah, that's one.
Even a movement of eye can, or a large angle kappa can be seen as keratoconus. So be very careful, check the angle kappa, check the quality of the scan, take 3 measurements. Then look at the steep keratometry. Then look at the astigmatism.
Sometimes you may have a steep, I'm giving you an example because I'm seeing a lot of those cases nowadays. You may have a steep keratometry 44, 48. You know, it's like, that's the way it comes, and it's like absolutely regular bow tie, and it's 48, so somebody has labeled it easily as keratoconus. So what is more, I would rather look at the elevation parameters. So that's something which you really, really need to see. Elevation parameters as to whatever she said, that more than 12 microns and more than 18. So you may have a keratometry of 44, 48, maybe 4 diopter of astig might be there. But if the elevation is not there, then it is not a keratoconus. That's it.
Coming to the treatment part, demographics are very important. Always be careful about the age of the patient. A patient less than 20, more prone for progression. 20 to 30 also there is a moderate risk of progression, and above 30, it rarely progresses. So the first and foremost important thing is tell the patient to avoid eye rubbing. If any allergic signs are there in the eye, treat the allergy, because these will trigger inflammation more. If the risk is low according to demographics for the progression, then you can go ahead with the spectacle or contact lens. You might also need a scleral contact lens if the astigmatism is high, or a RGP. If it is progression, if on a comparison map you're seeing a progression, then you have to go ahead with the crosslinking. What is crosslinking? It is nothing but a technique to stop the progression by cross-linking the cornea, increasing the collagen bonds in the cornea. So we instill the cornea with riboflavin, which is a photosensitizing substance, and we irradiate the cornea with UVA radiation. This increases the mechanical strength, and the cornea is now then becomes resistant to digestion by enzymatic action. So the first step is epithelium scraping, which is preferably done manually because alcohol causes more damage to the keratocytes. Then we drop by drop soak the cornea with riboflavin 0.1%. There are various protocols which I'll describe now, and then the third step is UVA irradiation. So these are the various protocols for progressive keratoconus. Depends on the pachymetry, whether it's more than 400 micron or less than 400 micron. Then depends on the duration, how much time you're irradiating the cornea. Depends on the pachy and if the epithelium is retained or removed. Okay, so these are the various protocols. and also depends on the type of riboflavin used, which is hypoosmolar and isosmolar. Hypo is used for thinner corneas, which will swell the cornea and prevent the endothelial damage during the procedure. Another modality is Intacs. Intacs rings are implantable devices. A pocket is made in the cornea, and this produces a vaulting effect on the central cornea. So it's basically like a bean bag effect. You're shifting the cone and then you're cross-linking the cornea. Then late stages, the options are transplant surgeries, epikeratoplasty or keratoplasty. So a history of hydrops is a contraindication for DALC because there will be desmet rupture and discontinuity of desmet membrane in DALC, and not a candidate for DALC. So I've made this own, a format. So I'll quickly revise the key clinical points of keratoconus. Take a very good history. Take a good history, ask about the duration of keratoconus, any history of frequent change in the glasses, allergies, any medication used in the past or present, any systemic disorder, family history of keratoconus, and contact lens use. Then do a good refraction, do a good retinoscopy, okay, to check the scissoring. Pachymetry is important to decide the thickness of the cornea, and if available, you can do a good biomechanics by your Corvus or OCT if available. So basically, any high astigmatism, you should be very careful, check the scissoring, check the K1, K2 readings, and then go ahead with the topography. Now, another cause of peripheral corneal thinning, the pellucid marginal degeneration. It is rare, progressive peripheral corneal thinning, and it typically involves the lower cornea in both the eyes, and presents mainly in adult life. In contrast to keratoconus, where you see Fleischer's ring, Vogt striae, happens early in life in your during puberty time. This is little more towards adult life. And hydrops is very rare in PMD. It is also important cause of gradual painless loss of vision because the patient will have increasing astigmatism. There can be asthenopic symptoms. There can be irregular astigmatism with flattening in the vertical meridian. When you see the slit lamp examination, there is a typical 4 to 8 o'clock area of thinning, 1 to 2 millimeter above the limbus. And the characteristic is the clear area has no scarring, no lipid deposition, and no vascularization. And the epithelium above this thinning is intact. So again, topography is very important. There's diffuse steepening of the inferior cornea and severe irregular astigmatism. And you see a classic crab claw-like appearance when you look at the topography. With the rule, astigmatism is more common in keratoconus, and against the rule is more common in PMD. Coming to the management, early cases can be managed with spectacle and contact lenses. Surgical options are not very ideal because these are not very well proven, and these patients usually are intolerant to contact lens, and in later stages they might need eccentric grafts or cricentric lamellar keratoplasty, wedge resection, or maybe Intacs. But cross-linking, I'm not sure. So what is your opinion about cross-linking? Do you cross-link PMDs?
Okay.
By and large, the PMDs which I have encountered have been very advanced. So they usually have corneal thinning, so they don't even fulfill the corneal thinning, thickness criteria. So I have not been able to cross-link. And the fellow eyes, when I looked at them, they had not shown any progression. So though there are reports people are cross-linking, but I'm little skeptical because limbus may get affected with that.
If one eye is keratoconus, another eye is PMD, then what is your approach? Even that is
No,
possible.
it's not there. It doesn't happen. They are usually ectatic disorders, so it's not possible.
Do you believe it's a spectrum? One eye can present as a...
I have yet to see. I have yet to see.
So it can be either or.
Yeah, it's either keratoconus or PMD.
So in one eye the cone is little up. And
Yeah,
one
it's
eye
my
very
eccentric cone. It's just an eccentric cone, but not really PMD. But you may have superior PMDs.
Okay.
You may have superior PMD or inferior PMDs, but it's not that you'll have conus in one eye and PMCD in the other eye. No.
So you don't cross-link, you just leave it like.
Yeah, not with UVs. So
But-
are you coming with something in NN? I think NN now.
I have seen one eye which was classical of when I saw the topography, not in NN but after NN.
Okay.
One fulfilling all the features of keratoconus, another PMD.
Maybe it
So
might be
those-
just early cones. Sometimes very early cones also come like that. You know.
So I was a little worried, should I cross-link the
No, it might be an
one?
early cone.
All of these patients are
Follow.
Don't jump in right now. Because nothing conclusive is there in the literature.
Yes.
So if you can publish something, come on and let's see how it works out.
Yes, sir. Coming to keratoglobus, it is extremely rare condition and this one presents at birth, unlike the other two. Cornea develops globular rather than conical ectasia, and the cornea has generalized thinning. So the topography shows a generalized steepening, not a focal steepening. So it's very important to differentiate it from megalocornea, which is having a normal thickness and normal curvature. So these are not megalocornea cases. Thinning may be diffuse or more marked in the periphery or mid-periphery, unlike keratoconus. Surgery is little difficult again, and contact lens is often not very satisfactory. Intacts can be tried, and cross-linking may have some utility, but I'm not sure. But the important point here is that you should tell the patient to protect the eyes, because even a minor trauma can cause perforation in these eyes. Terian marginal degeneration. Here it's little different. Here there is a gradual thinning and ectasia of superior and inferior peripheral cornea. It starts mostly superiorly. There is arcuate lipid deposition at the leading edge of the vascularization. So about 75% of these patients are male, usually bilateral, but maybe asymmetrical. Slowly progressive circumferential thinning occurs here, and very important is there is a peripheral gutter, the outer slope of which shells gradually, while the central part rises. So, and there is a band of lipid which is commonly present at the central edge. So there are two variants, quiescent and the inflammatory. Quiescent usually in the older patient, and the inflammatory variant is seen in the younger patient. It is associated with episodes of episcleritis and scleritis, and although perforation is rare, but can be there more in even with minor traumas. Pseudopterygium is there, seen in about 20% of the patients. So management, yes, for safety you can give glasses. Contact lens can be tried for astigmatism. Scleral or soft lenses with RGP, like the piggybacking, can be tried. And surgery, rarely when tried, can be a cricentric or annular excision of the gutter with lamellar full thickness transplantation. So tectonic corneal grafting basically. So here I've tried to compile the difference between PMD, terian and keratoglobus. Age of onset, usually keratoglobus is the earliest, present at the birth. PMD and terian middle to late age. All of them can present bilaterally. Male preponderance is there in all three of them, unlike keratoconus, which has female preponderance. Astigmatism, all of them. Dominant teratins can be seen in keratoglobus, other two are sporadic. Inflammation is not seen in PMD. And terian classically presents with vascularization and lipid deposition. Prognosis is poorest in keratoglobus, and perforation is unusual but can be seen with PMDs. Another rare variant which you might not have seen but we come across regularly is post-LASIK ectasia. It is also a type of corneal ectasia. How we define PLE is inferior steepening of 5 diopter or more compared with the post-op scan, not pre-op scan, and loss of 2 or more Snellen's line of uncorrected visual acuity. So here there will be a change in manifest refraction in either sphere or cylinder of 2 diopter or more. Very, very terrifying situation for a surgeon. And this is the risk scoring system. So we should be careful pre-operatively to, if any topographic abnormality, be very careful. Look at the residual stromal bed. It should be always like little more than 250. Young age people are at risk. Let the refraction stabilize and then go ahead with the LASIK. Do not touch very, very low corneal thickness people, and patients with high myopia, be little careful. And it presents 1 to 12 months after LASIK procedure, can be later also. And there is a regression of the refractive effect. Patient will say, I cannot see as I was seeing before. And there is loss of uncorrected and best corrected visual acuity. Patient can have irregular astigmatism. So management includes, again, try rigid contact lenses. You can go ahead with Intacs and cross-linking. Make sure you do not put your Intacs in the LASIK flap. It should go in the channels created for Intacs. And then in the advanced stages, maybe penetrating keratoplasties. I would stop here. So, any feedback or